Hello and welcome back to Psychology 303, the analysis of everyday behavior. This is Dr. Williams, and this is our last lecture for Unit 4. It's over Chapter 18, Positive Punishment, and the Ethics of Punishment. So let's get started talking about positive punishment. Remember that positive punishment is defined as the application of aversive stimulation or aversive activities contingent on the occurrence of misbehaviors by the client or the individual, the student, the child, the whoever. And there are several different kinds of positive punishment. This is a list, it's not a complete list, but it is a list of different kinds of positive punishment. It includes aversive stimulation, overcorrection, contingent exercise, guided compliance, and physical restraint. And under the category of aversive stimulation, this usually includes a number of possible outcomes for misbehavior in children or adults with and without disabilities. So spanking is considered aversive stimulation, reprimands, aromatic ammonia. The use of ammonia has been employed as a punisher for treating child molestation. So in addition to other forms of therapy, having convicted criminals view slides or films of children and measuring sexual arousal using something called a penile plethysmograph that detects arousal and then delivers through a cannula in your nose that delivers a whiff of aromatic ammonia, which is extremely aversive and tends to decrease sexual arousal in the presence of certain images. It's never used as the sole type of treatment, but it has been used in conjunction with other treatments. Facial screening. So when individuals misbehave, their view is blocked either by putting a blind in front of them or using your hands in front of their eyes. For people with disabilities, this can be a very effective form of punishment. It's not painful, but it is aversive. They don't like to have their view obstructed. And then more extreme versions, electric shock has been used. We've talked about that in class, only on a very small number of people, and the electric shock is relatively mild. Aversive noise, even a squirt of lemon juice into a child's mouth has been used to punish regurgitation. So children who refuse to swallow, or when they do swallow, regurgitate their food, if you put a little eyedropper into their mouth and squeeze a little lemon juice, it can lead to, it's unexpected, and it can lead to a decrease in regurgitation. So these are just all kinds of different therapeutic treatments that have been used in the past with larger or more limited populations. Overcorrection is another type of positive punishment, and there are two types. There's positive practice and restitutional overcorrection. And I'm going to talk about those in a little bit more detail in a few minutes. And then we'll also go into some details and some examples of contingent exercise, guided compliance, and physical restraint. So with respect to our first category, contingent punishment, most of the time, under typical conditions, contingent aversive stimulation is usually viewed as a method of last resort. They want you to try other methods. We want to try more appetitive methods and more less restrictive methods if possible. Only when those methods fail or are deemed too slow or inappropriate do we shift to punishment as a primary form of behavior modification. I've had all of you read about the least restrictive alternative law. And so in those rare cases where you have individuals who engage in self-injury or become a danger to care staff or others, occasionally punishment can be used as early on or first to simply suppress the aggression or self-injurious behavior and begin training alternative responses immediately. In the cases of risk to the client or others, we need to stop that behavior as quickly as we can. And often punishment is a good way to stop those behaviors rapidly, and then we can move on to other forms of training. All right, so I think we came up with all of these examples, and I sort of talked about them a little bit. But spanking, reprimands, aromatic ammonia, facial screening, electric shock. We have talked previously about Brian Iwata's work with percussion-sensitive helmets that deliver a mild electric shock to the back of the individual's arms in response to banging their heads. And although it hasn't been used extensively, it's only used on a very small population, it's effectively allowed these children to remain living at home and not become institutionalized and even mainstreamed into regular classrooms. So it can be very effective in eliminating those behaviors and then replacing them with behaviors that are more appropriate. Aversive noise, the use of lemon juice for refusal, for food refusal or regurgitation, have all been used effectively, but only after other methods were deemed inappropriate or ineffective. Overcorrection is another form of positive practice, another form of positive punishment. There are two types, positive practice and restitutional overcorrection. Positive practice involves having the client or the individual, the child, when they engage repeatedly in the correct behavior after an instance of inappropriate behavior. So we have lots of examples of this in our everyday lives. So, for example, when you go to the pool, you'll find that the lifeguards will tell kids not to run. And if a child runs anyway, then they are told to go back to the door and walk appropriately before they can get in the pool. So engaging in the appropriate behavior rather than allowing them to get away with the inappropriate response. In a classroom setting, if a child gets angry and gets up and storms out and slams the classroom door on their way out, then you might have them come back at some point and engage in positive practice. How to get up, walk to the door, open it, and close it quietly, and then go back to their seat and do it over and over and over again. Having a child who's grabbed a toy from a playmate practice how to ask politely if they may have a toy. All of these are forms of positive practice. Restitutional overcorrection, on the other hand, typically will involve something that looks a little bit like positive practice, or it may simply be correcting any environmental damage that's occurred as a result of the misbehavior. The goal here is to correct the damage. So if a child writes on her desk, then she has to come back and clean her desk. But the overcorrection part is that they have to then leave the setting in better condition than it was before they misbehaved. So the child would not only be expected to come back and clean her own desk, but she might be expected to clean all of the desks in the classroom after school. Or a child who's angry kicks a trash can might be required not only to clean up the garbage that's gone all over the floor, but they might also have to pick trash up all over campus, all over their school campus for that afternoon. Contingent exercise is a positive punishment technique that involves applying aversive activities like push-ups or jumping jacks or running laps contingent on an undesirable behavior. This is, I've mentioned this before, but the U.S. military uses this a lot to gain better compliance control over new recruits. It's different than overcorrection because the exercise is not really related to performing a behavior correctly. So if you were in the military and you didn't respond properly to your commanding officer, he might make you run laps. Running laps and speaking properly or addressing him properly are really not related to each other. So this would just be contingent exercise. Physical activity is usually unrelated to the undesired response. So in 1980, Luce and some of his colleagues showed that they could use contingent exercise to reduce problem behavior in schools. And I mentioned in class earlier that I had a student, Candace, who worked with a little boy who he was told, if you want to, if you misbehave, you're going to have to go out and do exercise with Candace. And first he thought, hey, cool, I like Candace, and he misbehaved a lot. But as the jumping jacks and the sit-ups became more and more aversive, he became less and less willing to misbehave, to be alone with Candace, because it wasn't really as much fun as he thought it was going to be. All right, guided compliance. Guided compliance is actually a positive punishment technique. It usually involves physically guiding a client through a desired activity. Typically, this is when it's contingent on failure to perform the activity at all or deliberate misbehavior. Guided compliance can be used to, can only be used if the physical guidance is aversive. So in other words, having someone guide you through the steps of doing the behavior appropriately is only considered punishment if the child doesn't enjoy it. Otherwise, it's not a punishment procedure. You have to be careful because physical guidance could also, for one individual may be punishing, but for another individual it could be negative reinforcement, since the physical guidance is withdrawn immediately if the client begins to complete the activity on their own. And for others it could be a positive reinforcer because it's a form of attention. So you have to look at how it's affecting behavior to determine whether it is a punisher or a reinforcer and what kind of punisher it is. Finally, physical restraint is also a positive punishment technique. It's also called a therapeutic hold. Contingent on misbehavior, the child or the teen or the client is held immobile and restrained from continuing the undesired behavior. So they often will wrap their arms around the individual. They'll pull their right arm around to the left side and the left arm around to the right side, and they'll hold on to them from behind. Or they may simply hold the individual's hands, where they take the hands and twist them inward and hold them down so that the individual can't actually do anything with their hands. Or it could be a full body restraint. So it just depends on the type of restraint that you decide to use. One variation is called response blocking, where you simply reach over and you prevent the individual. You hold their hand to prevent them from engaging in a behavior. So, for example, with self-injury, if they're hitting themselves with their hand, if you hold their hand, if you use physical restraint on their hand so that they can't actually hit themselves, then you would be using physical restraint. The attempt is, the goal here is to use as little restraint as possible to prevent the undesired behavior. So, response blocking has been used effectively in hand mouthing, so children who put their hands in their mouths, for thumb sucking, for very mild levels of self-injurious behavior, and it seems to work fairly effectively, as long as it's consistent, immediate, contingent, all those things associated with punishment. So let's talk a little bit more about physical restraint. Here's some examples of what physical restraint can look like. I think it's important to remember that there are risks associated with punishment in general. And so regardless of the type of positive punishment that you're using, or the type of negative reinforcement that you're using, you need to be aware of these risks. First of all, remember that punishment alone does not teach alternative behaviors. So it only tells you what you've done wrong or what isn't working anymore, and it doesn't actually show you what you should do instead. So your client is told, you're not allowed to engage in that behavior anymore, but I'm not going to show you what you can do instead. And so that's a bit of a limitation with punishment. Remember that intermittent punishment is equivalent to intermittent reinforcement. So if you don't want to make the behavior stronger, you may need to opt for something other than punishment if you can't deliver it continuously. If the punishers are delivered without there being a contingency related to the target behavior that you want to eliminate, if there's no contingency and they just receive punishment at random, it's not going to be very effective at suppressing the behavior that you're interested in suppressing. But it will suppress behavior overall. You'll just get less behavior overall. Habituation risk. If you use really low levels of punishment, or if you use moderate levels of punishment really frequently, you will run the risk that the client will begin to habituate to those levels of punishment. And to get the same effect, you may have to increase the aversiveness of the stimulus or of the punishment in order for it to be equally effective over time. And of course, escalation to abuse then becomes a possibility. So you have to be careful. And then finally, you can increase the undesired behavior if it serves as a signal for positive reinforcement. We talked in class about child abuse, where children learn to push their parents' buttons, even though it often leads to punishment, because sometimes the punishment is more attention than the child gets on a regular basis. Or after the punishment's delivered, parents become apologetic and affectionate. Spouses do this with their honeymoon period after an abusive incident. The abuser becomes very apologetic and loving and emotional, and these are things, the kinds of reinforcers that you don't get any other way. And so we have to be very careful that we don't follow punishment with large-scale, out-of-proportion reinforcers. Otherwise, you can end up in a situation where your client is engaging in misbehavior, not because they want to be punished, but because of the high value of the reinforcers that come immediately after punishment. And then, of course, because of all of these things, you should always consider other approaches first. Really, it should be the method of last resort, except in cases of extreme risk to the individual or to others. So my recommendation is to first and foremost consider alternative treatments. Try functional interventions first. Try to identify what the reinforcer is and try to train appropriate behaviors if you can. Employ the use of differential reinforcement. So punish the behavior that you don't want, but provide positive reinforcement for alternative behaviors. Always consider doing an FBA analysis by looking at the ABCs of behavior to see what function the behavior is serving, what's maintaining the behavior, and that will also help you identify what are the consequences that are maintaining the behavior so that you can develop appropriate alternative responses that lead to the same reinforcer. But always remember that an FBA can only be conducted if it's safe for you to do so. If there's a risk that the individual could hurt themselves or other people while you're doing a functional behavioral assessment, sometimes you have to step in and stop the behavior immediately. Choose your aversive stimulus carefully. It should be aversive in order for it to be effective. There's a risk that it could serve as a reinforcer. So what might be a punisher to you could be someone else's reinforcer. So being yelled at and getting lots of negative attention might be very punishing for you, but for your client, it may be the only one-to-one interaction that they get all day, and it may be actually serving as a reinforcer. And then always get informed consent from the people involved, the client, if they're capable of giving consent, the parents, the teachers, the administrators, and then also have other colleagues review your procedures before they're implemented. Have other therapists or other intervention specialists. When you go off to grad school, you'll be trained with a whole series of people. It's always a good idea to stay in touch with your cohort individuals so that you can send off a copy of a protocol and have someone look at it. Sometimes they'll make suggestions that would be actually an improvement. And so you want to make sure you stay in touch with your professional colleagues. Ultimately, the ethics of punishment are directly related to an individual's right to effective treatment, as well as the least restrictive alternative law. And punishments are referred to as restrictive procedures, generally. And so there are certain precautions that you have to take in order to be able to use punishment as in a therapeutic manner. Clearly, you have to be familiar with the least restrictive alternative law and how it relates to your particular field of interest. You need to obtain informed consent, preferably in writing if possible. You have to ensure that the individual who will be punished for their misbehavior, so the behaviors that are being punished for that particular client, the first goal is to do no harm. So you can't use punishment if it's going to do irreparable damage to the individual. We also need to consider problem severity. Punishment has so many side effects that to use punishment on a behavior that's not very severe and might be amenable to other treatments would be unethical. So we try to reserve punishment for those problem behaviors that are high in severity and high risk to the client or to others. Make sure that you develop implementation guidelines in writing, that you develop a formalized written treatment plan for the individual that includes a clear operational definition and description of the contingencies that lead to punishment, so that you have it in writing and it's outlined very clearly so that those individuals who become the delivery agents can always go back to those written guidelines. The field of applied behavior analysis now requires that you have special training and special supervision in order to use punishment like electric shock. It has to be an area of specialization within your graduate degree. And so there are certain schools where you go to get that kind of training and supervision. So they're trying very hard to restrict who's allowed to use those procedures so that they don't become a standard go-to method of behavior change. You need to always make sure that you engage in peer review. If you're at an agency, then you want to go through your human subjects research council. You want to talk to, if you're working with children at home, you want to talk to CPS and make sure that they understand what you're going to be doing and what your procedures are, and that they approve and sign off that they consider this to be an appropriate treatment given the problem. When you're working in an institution, you need to check with the other staff, with your colleagues, and with the administration. If you're in a school, you need to talk to the teachers and the parents and the counselors and the other individuals. And finally, accountability is really important. It's really important that you obtain the required training, that you have a clear assignment of duties to the different individuals involved in treatment, and that you engage in clear and thorough record keeping and documentation. All right, so I'm going to stop there. That's our last lecture for Unit 4. Good luck with the test, and we'll see you back for the chapters in Unit 5. Have a great day.